Welcome everyone. I'm Councillor Matthew Whittington, Cabinet Member for Community Wellbeing, Health and Care. If the continuous fire alarm sounds, please evacuate the room by the stairwells. Do not attempt to use the lifts. Please assemble in the turning circle at the end of King Henry I Street past the Park building. There would have been no one who signed in at Guildhall desk. There's also no members of the press or public. Please can everyone use the microphones and remember to switch them off when they have finished. So, just do some introductions, starting on my left.
Anna Martin, Democratic Services.
Richard Webb, Deputy Director of Finance.
Pecking order. Andy Riddle, Director of Adult Social Care.
Hannah Byrne, Public Health Principal.
Helen Atkinson, Director of Public Health.
Brian Madgett, Portsmouth Councillor on this committee.
Councillor Graham Heaney, Labour Group Spokesman for Community Wellbeing, Health and Care.
Councillor Lewis Gosling, Conservative Spokesman on this committee.
Thank you very much. We have no deputation requests and no apologies for absence. Members, any declarations of interest? No. Thank you. Okay, so straight on to item 3 then, outcome of the integrated sexual and reproductive health tendering process. Over to you, Hannah.
Thank you. So, working with colleagues across Hampshire, Southampton, Isle of Wight and within Portsmouth, across the local authorities, and with our NHS colleagues, we've completed an open tender exercise for the next contract of the integrated sexual health services, which includes a mixture of sexual health services and including HIV care with the NHS. And we're pleased to announce that Solent were the successful bidder due to initiate the new specification from the 1st of April 2024. We're really excited about this collaborative outcomes-focused specification. While the services remain the same and our approach and really strong workforce, we look forward to continuing to strengthen the resources available across the wider system.
Thank you very much, Hannah. Short and sweet. Obviously, we've had the paper members. Any comments or questions? Graham.
A question, is it possible to know who the tenderers were?
Thank you for the question. I'm not quite sure if that's a commercially sensitive question, so I would have to say that away and just double check that with my partners, if that's okay.
I'm just interested to know who else would have tendered for such a service, whether it was a public organisation or a private sector organisation, because it's interesting. I do have a comment, just looking at the last paragraph, 3.4. In fact, the Scrutiny Management Panel has started a review of the systems thinking process to look at what's been going on in the local authority historically, to see where it's been adopted and what the success is, and to look at whether there are lessons to be learned from that, and also whether there's any desire to maybe see this rolled out more comprehensively across the authority. And interestingly, we had a presentation last night on the integrated sexual health service, which was really interesting because it showed both that the professionals involved in the service were really willing to embrace change and to look at doing things differently, and that the success of that intervention and the work that went with it and all the work behind it has made significant improvements both to the quality of the service for the people using it, but also improved efficiency, because it seems we're actually seeing more people. So I was really impressed to hear that last night, and it's just very convenient that obviously I read the papers when I went home and thought, oh yes, I've just been hearing about that. And so congratulations to all those involved. It was really good.
Thank you. And in response to that, I'm really pleased to be able to go to national meetings and talk about the work we're doing where other areas are struggling, and we've been able to talk about the approach that we're taking, the collaborative approach, and the of using the systems thinking approach, and how we're making a change and improving what we're doing, continuing to do. So yeah, it's very exciting, and it's great to be putting Portsmouth on the map with that work as well.
Brian. Being as I'm new to these sort of contracts things we've got here. 3.4, I did speak briefly with Graham about it earlier. 7-year contract plus 2,251,800, 20,266.200. What happens if inflation goes berserk? Is there things in place, or is it down to them to sort their own problems out? Because, you know, the 2.2 million in 9 years' time could be 1.5 million in, you know, sort of financial terms. What happens there if inflation goes right up?
Thank you, and it's a good question, and it's one of the questions that gets asked by those looking to bid for such contracts. Our public health grant that comes down to us, we get information about what is mandated, and sexual health is one of those mandated services. And in general, for what they call the NHS Pay Award, we get instructions about if there's additional money coming down and what we should be doing with that funding to help with things like staff inflations. So that's one thing. There's always advances in the world of sexual health medicine and around behavioural change and the wider context. So we're constantly working in collaboration to strengthen those resources, because we don't know what will happen with funding. We don't know what will happen with infections, diseases, demand on contraception service. So it is something that we do need to keep a close eye on and continuously think about sustainability and transformation, which it really is business as usual in our work, which is why it's really important that we've got that good transparency about what our residents need and what's available.
Just to put that into a wider public health grant context, so you'll know that this contract is funded from our ring-fenced grant, and we don't know ahead. In fact, it's usually, looking at Richard, usually sometimes even after the end of March when we get told what we're going to get in the grant. So we do have to really manage what in effect are our contracts, which will have growth in, because we just don't know how much we'll get. But importantly, which is really helpful, because it is an NHS service, we do work closely with the regional director of public health who works in the regional NHS team to ensure that we do get some funding if there is, for instance, a gender change. So you'll know that there's quite a lot of the professions currently, junior doctors, consultants, radiotherapy, or, you know, are asking for uplift. So we do negotiate and work closely with regional NHSC and national colleagues to see if we will get an uplift in the grant alongside the uplift that they negotiate with frontline staff, because it's obviously it would seem a little bit unfair.
Yeah.
So it's not just, you know, inflation. If there's a new AIDS of some kind, a new disease comes through, I would assume that this doesn't stay at 2.2. I presume that, you know, because there's going to be a hell of a lot of extra money needed, do we pay that to the council, or is that through the government if we get a new disease comes through?
So I can give the example of it was Mpox. It was known as monkeypox in the press at the time. So when Mpox came out, it became something that we needed to address across the country. We had these conversations nationally to look at ensuring that the vaccination cost was covered, and looked at how we could optimise on the system to ensure that actually, as well as being able to provide that care, but we were actually able to benefit from those additional contacts with those residents as well. So yeah, it's where we do come together, and so Helen's got her links with the regional directors of public health, and I sit on a national executive committee around sexual health as well, which gives us that, which is an advantage for us in Portsmouth, because we're able to be around the table of those important conversations around finances nationally to ensure that we can look for investment to help us address things like new emerging conditions.
And in that instance, the NHS funded the vaccine.
Yeah. And it's why prevention is always going to be a really big thing of public health, because we need to ensure that we're continuously trying to make sure that we can manage those conditions.
Thank you very much. Thank you, Chair.
Lewis?
Just a couple of comments from me. Firstly, just to pick up on the point you made to begin with about how wide-ranging the conversations have been. So in terms of the geography of how big a contract this is something that should definitely be celebrated, just given the remit that these teams have and given the effects on people who might be seeking treatment. It's good to know that our residents actually don't just need to go to somewhere where they might feel that they're going to bump into somebody or something. They've got the option of looking at regional sites as well as locally. And then my other comment just to pick up on was obviously quite a lot of the points on the outcomes are around HIV testing and the treatment for people, and it was just a good time to throw in and celebrate the extra money we've got for opt-out testing to be rolled out in Portsmouth now as well. So hopefully that should fit in really nicely with this new contract starting as well.
Thank you. That's a really good point, and we're really pleased that our sexual health service has got that good relationship with the hospital, so we should be able to really make the most of that.
It is important to note, though, that that money is NHS funding going directly to the trust, but importantly, it will identify, and that's the whole point, it's being rolled out now. The pilots have identified new cases, but again, HIV is commissioned. This is the bizarreness of how services are commissioned across different organisations. HIV is commissioned by NHSE. Sexual health is commissioned by local government, but this is where Hannah, with her experience, comes across to do a lot of that sharing, so that we're commissioning to a certain extent together. Is that?
Yeah, we commission together and we've got great relationships. So yeah, NHS fund the treatment and care, but we fund the prevention and have peer supporters as well. But it's a really good collaborative approach, and thankfully we've got that great relationship between the commissioners. And yes, going back to the being able to, for our residents to be able to go to other clinics, we've really been able to maximise on that through the new clinical front door that's come out of the systems thinking work. So we can ask the residents, where's a good time for you based around your wider needs, and it's the positive feedback from residents is great to celebrate, and it's also great to share with other professionals, because it's great to have success stories, isn't it?
Thanks everyone for their comments, and thank you so much, Hannah, for the reports, and of course Helen as well, and the rest of the team. We are very fortunate to have Hannah. It was dropped in there about the national body she sits on, which really does give a view to her expertise in this area, and she's been working extremely hard on this with our partners in Hampshire, the Isle of Wight and Southampton, in getting this tendering done, and obviously getting the contract that we've got in Portsmouth. And thanks for bringing up about the systems thinking. I think that is, we've done a lot of systems thinking within the council. We've done things with voluntary community social enterprise sector, but I think this was the first time we'd really done it with the NHS, and that was a potential real banana skin. There was a lot of anxiety about doing systems thinking with the NHS, but actually the staff there really engaged with it, and it was a really successful thing. As Graham said, I'm sure they reported back at scrutiny management as well. But it really does show that that's a kind of approach that I think we would be looking to take forward more of in the future, and obviously there's other work going on already. And again, it's been brought out by Lewis in particular about the scope of this, because of that working, and because we've effectively maxed out our potential of what we can do with it. It actually means it does cover a lot of space, but it actually does it very, very well. And I'm really pleased that we can continue working with Solent NHS on this. And I was talking to the Deputy Chief Operating Officer who covers sports with Joe Pinthorne, and again they're so positive about this contract and taking this forward. And then just on that final point, as Brian said, with the money, yeah, it's one of these things where within local government we are all the time sort of really going to government and saying, make sure we properly fund public health. And that's a really important thing, because it is things like this. We know there's going to be uplift in the money needed, as has already been mentioned about if there's particular things that come out that become more of an issue, then we have to sort of deal with it. We need that extra funding, and it's one of those strengths of local government coming together and us doing this in our partnership in Hampshire and Isle of Wight, that can really show we're not just doing it as Portsmouth. We're not just doing it at that macro level, but we're actually doing it at our sort of regional level as well. We can say we've got those things. And finally, as Lewis has mentioned it, yeah, it's great. It's so fantastic to hear about the funding for the opt-out testing, which is going to be coming to the QA and Southampton, of course, so in our area. So that's going to reach some of our people who might be out of town, have something go wrong, and they're in the Southampton area and get tested there as well. So it's something that I think will make a real difference to people, and then we can also work together with all our sexual health services. So very happy to note the report, and thank you everyone for your positive comments, and again thank you Tanner for your team and your team again for all the work that you do. Okay, so if we move on to item 4, Portsmouth Carer Service. Over to you, Andy.
Thank you, Chair. So the paper in front of you is to provide an update on part of our preparations for assurance for inspection from the Care Quality Commission, which will be coming at some stage. We know not when currently. But this is related to informal unpaid carers. As you'll know, in Portsmouth, while CQC treat it as a significant theme in their assurance and inspection, we also see unpaid carers as a very important part of our health and care arrangements in Portsmouth. So we've used a tool under point 4 going forward. We have had a strategy that ran until 2020, developed in partnership with those organisations listed there. Unfortunately, the impact of the pandemic and various capacity constraints have delayed the publication of an updated strategy, but we're anticipating that will be completed by March of next calendar year. We do have a plan by which we run the Portsmouth Carer Service, and that was published in March of this year and will be due to be renewed at the same time next year. And that's based both on performance data, i.e. how we perform against things that are important to carers, but also through feedback events and working with our residents in Portsmouth who are carers. And we just listed the 5 priorities there: improving targeted, practical, emotional and psychological support to remain in work, improving identification, communicating and engaging, and making sure we do what we've agreed to do. So under the Care Act we have statutory duties. This gave parity to carers with those people that are receiving services or might receive services, have needs. And so we conduct an assessment, and the offer that we make can be a mix of statutory services and or preventative services, and planning to enable carers to continue caring. So looking at our unpaid carers data against this tool of assessment that we used, we can show good quality and accurate data, but we also have some work to do around our data. We can see, how long it takes us to assess from a referral for somebody, and how long it then takes to deploy that support. And we have low waiting times for assessment through our carers service. That helps us be preventative, because if it takes longer to get to somebody, of course, then their situation can change and become worse. And we use that data for service planning. Moving forward on the second paragraph, 4.3, we do have some work to do with our System 1 case management system relating to something called client level data that provides a far greater focus on what's happening in the outcomes for individuals. Such as, for instance, parent carers. So whilst there's an overarching title of carer, you get people who are parent carers, you get people that are young carers. So improving our data will enable us to understand how well we work with those groups within the caring community. We think our data is relatively comprehensive, but we're very clear that we've got work to do on it, and we've got a plan to get on with that. We then talk about joint assessments, where we're working with both the person who's receiving care and the carer. We have some work to do to make those better, to offer a greater opportunity for those, not just to have independent carers assessments, because sometimes for people they want to see each other in context and receive services and support together. Then moving through into 4.5, we have a website that's very accessible. We have regular engagement events with carers. We also submit data to the ICB around direct payments for services for our carers. We're not always able to evidence through data the extent of the diversity of provision. So thinking again around parent carers, we can show that we assess separately from the young person they care for, but we're not able to quantify that due to our data collection processes, which sort of gives an example of why we want to improve the way that we collect data. We also talk about young carers, so coming toward the end of section 4, so people who may be turning 18, our residents who may be turning 18 and perform a caring role. And we base our service in the early help and children's services, but we do have a lot of liaison between our carers services and our young carers services, and trying to ensure in the same way that we do for our residents with care needs that turn 18, that our young carers have support as they progress through that life course. So on the summary point there, we've used the LJ Carers Criteria for Assurance, which was the point of this exercise. We feel that we've got some good solid evidence of the way that we work with our carers in Portsmouth, but we do have some work to be done, and that'll be part of our improvement plan going forward into the next year. I hope that's helpful. Happy to take any questions.
Thank you very much. Andy, any comments or questions? Lewis.
Just from me to pick up again, I know I've raised it a few times before, but it's good to see us going back over and reviewing a lot of this stuff. I know with the thought of inspections and stuff like that sometimes can be daunting and can add on additional work, but it's good to see that even in services such as our carers service, that I think everyone will agree on the whole is a fantastic service and provides such benefit to residents, that there is still improvements we can make and there are still added little tweaks we can do to just up the game on that slightly more. So it's heartening to see that actually all of the work that needs to go in for assessments and stuff like that does provide real outcomes for people.
Thank you. I think it's really important as well, because inspection is a huge amount of work, and we've now seen the 5 pilot authorities report that were inspected over the summer, and they've reflected that the effort shouldn't be underestimated. But I think there's also a really helpful narrative emerging that doesn't just focus on inspection and the potential consequences, outcomes of inspection, but sees it as a spur for improvement and continuous improvement. So that's really helpful, I'd agree.
Thanks. Any other comments or questions? Right.
Yeah, thank you. I just wanted to ask about the paragraph 4.3. You're talking about not being able to measure satisfaction or quality of life particularly well. And I think, Andy, you did mention that you were planning some measures to try and address this. I mean, one of the ways would surely be to do some sample surveying of residents and asking specific questions around that. Is that part of what we're going to do?
We do some of that already. What we do every other year is a carer survey. It's a national requirement upon us, and one of those measurements is quality of life and whether carers have contact with as much social contact as they like. I think our issue with it is once every couple of years isn't really sufficient to understand how you're performing and how the impact of the support that you're providing is supporting people in their everyday lives. So yes, I think that sort of co-production, that sort of consultation is something we'd like to get better at. I think we've also been very fortunate lately in that we've engaged some support from our engagement team in the council. There is an engagement team that work across the council, and we'll be hoping to use that resource to help us get a more contemporaneous feedback from carers, I think.
Thanks. And thanks for your comments, members. Yeah, just to say thanks, Andy, as well for the report, and of course for Ben and the team at the Carer Centre, and obviously put this together. And I think the point I was just going to bring out was, as you see in 4.1, so we're expecting to have a new strategy by March 2024. And that will also be when we'll be renewing our carer centre strategy. So that will all fit in together, which I think is obviously an important point of doing that, and obviously working with all of our partners within the system. Just as a question, Andy, as you mentioned it, so you said that we've had the 5 authorities, the reports come from the 5 authorities that were the pilot ones for inspection. Do we have any kind of time scale for when we think inspection might be coming our way?
We don't at the moment. So the last update that we had as recently as last week is that the secondary legislation which is required to give CQC the powers to inspect under the Care Act duties had been submitted to the Secretary of State. There wasn't an anticipation that there would be unreasonable delays in getting that signed off. And I'm a little rusty on my legislative stages, but I don't think it requires a full debate in the House for that to happen. At CQC, we're saying what they would do is they would then name the next tranche. Now, originally they talked about naming 20 other local authorities. Whether that's still the same number or not, I don't know, but the commitment last week was still that it would be in this month, in December, that they would start to notify those other authorities. Whether Portsmouth is one of those, they're not really giving us chapter and verse on how they'll decide on the first tranche. What they're saying is that they'll probably choose a mix of different size authorities, unitaries, counties, geographically diverse, different levels of deprivation, that sort of thing. So I think they'll try and include a reasonable mix within that first formal tranche, but outside of that, we don't know.
My understanding only is that the pilot authorities, the way that those inspections were done, is sort of is helped support the way that inspection is going to work as a standard.
Yeah, absolutely. And so whilst the CQC undertook some learning experiences earlier in this calendar year with, I think it was Hampshire and Greater Manchester, or Manchester City might have been. These 5 were very much pilots. We're seeing a bit more published each week at the moment. The initial 5 pilot reports were only published about 2 weeks ago, I think. And now we're starting to see more and more the LGA publishing things on their website and just drawing out some lessons and some feedback. We heard quite a lot at the National Children's and Adult Social Care Conference last week from the couple of the authorities who underwent inspection. So we will start to see more. The 5 pilot authorities gave them opportunity to test and learn again, and so they're saying this will develop over time.
Yeah, and speaking of NCAS, we had the Chief Adult Social Care Inspector there, didn't we, who's a former DAS of Norfolk. Yes, that's right, who I know we'd seen before, who's very experienced in that area, which is encouraging in itself that they haven't got someone from outside doing that. So, yeah, I mean, I don't really have anything more to add to that report, but obviously looking forward to getting the carer strategy coming, and obviously this is, as has been pointed out by yourself, Lewis, this is almost inspection, though it is a lot of work. It does galvanise you to have those updates and see where we are in terms of areas like this. So it can be quite helpful as well, though. Quite how helpful it will be in the long term, who knows? But yes, so very happy to note that report. So on to item 5, back to Andy for shared lives, strategy and development.
Thank you, Chair. So the paper in front of you is a relatively short paper talking about the plans for the shared lives service within Portsmouth. Under 3.1, we've gone into some of the background of what shared lives is. It's a very valued, highly regarded service. It's receiving care within a family environment, in effect. We've also provided Appendix 1 a more detailed overview of how the service works in Portsmouth. And then under 3.2, gone into a bit further detail around numbers, 34 adults across 25 registered households, and the number of people that there's a majority of those folk are in the over 65 age group and have been in long-term placements. The government have taken an interest in shared lives and growing shared lives services within local authorities, and CQC are also commend shared lives. 96% of schemes are rated good or outstanding, which sort of is a testament to the value and to the quality of the schemes, really. And then we've included some outcome measures there, which broadly speaking are talking about how valued these schemes are for the people that live there and the carers as well. And we've seen quite a significant growth in shared lives services, particularly for those people who need support in relation to their mental health, living with dementia or parent and child arrangements. And care leave is particularly important. We know for a lot of our younger residents who have had experience of being in local authority care, being able to have that stable, supportive, emotionally supportive environment as they turn 18 and progress through adulthood is really, really important to them. We're proposing in Portsmouth to invest in shared lives, and we've set out the aims in the last part of point 2 around why we're doing that. And then under 3.3, we've referred to some funding arrangements which we've gone into more detail on in the second appendix. We then talked about our recruitment activities. There's a rolling campaign, and we had some notable successes in Shared Lives Weeks. We had some stuff on local radio in addition to all of the other media outlets that we use, which was really helpful. We had a lot of positive feedback from our use of social media. And then under the 4, we've put in there our project plan, part of that being done this year, part of that moving into next calendar year. And the hope is to expand the service, provide more environments for people to live. And we've talked about some of the challenges in risk, but particularly in Appendix 2, we've talked about the financial benefits or prospective financial benefits to being able to expand shared lives. So we know from all of that feedback, from all of those indicators, that it's a very positively regarded service and has good outcomes for residents. But we also know from those financial analysis that it's a more cost-effective way of providing care. This is the table that's on page 6 of my report, but maybe on the last page of your report. Talking about comparing the costs of provision, care home provision and residential care as against what it costs for shared lives. So tried to include quite a lot of information about the service. It's really very valued by our residents who use it. We want to expand it, it has good outcomes for people, and bringing that really is an update of our plans here. Happy to take any questions.
Thank you, Andy. Brian.
Thank you, Chair. Put my other hat on, Andy. You know I'm involved in the younger children. The 18 to 25-year-olds who go into this shared lives, when they're 25, do they tend to want to come out and live on their own or live with mates and things like that? Or do they tend to want to stay in that shared lives environment? How do, I know you go up to all ages there, but do the ones who've actually come through our own system here, do they tend to want to then get out of the council system at all? What's the percentage, if you've got a percentage on it? It's not an easy one, mate.
I can't give you an exact percentage, but what I'll do is take that away and come back to you on it. It will very much depend on the needs of the individual. So for some people, as an example, if they've been having support and care through foster care, their foster carers might want to become shared lives carers for that continuity of care, and that young person may need that care for a greater or lesser period of their life. If somebody's wanting to move on, if they feel they've been able to develop those independent living skills, or we can help them to do that through that placement, then we'd absolutely work with them in the same ways we would any other resident coming out of care to move on. whether that be to a more supported environment first and then sort of moving on to independent living, or whether that be straight into independent living. So it very much depends on the needs of the individual and their wishes. But what I'll do is I'll take that question away and come back to you with a more statistically accurate answer.
Thank you, Andy. Just one thing, when the likes of most of us here were brought up in a family environment, we tend to fly the nest between 18 and 25. Is that similar to your figures there? Would that be with the people who are in care who actually want to come out of care and live independently completely? Can that happen? Does it happen?
It can happen. I think I'd probably say as a broad statement rather than a detailed statement, if somebody is turning 18 and they're going to need some adult social care support, it's necessarily a slower journey. Independence is something that we value and we try and support all of our residents with at whatever stage, in whatever way that they can take advantage of that. I mean, independence can be very small things through to living your life completely independently. But if you're in need of care and support when you turn 18, it would necessarily be a slower journey normally. But that would actually be focus. I'd give an example. I guess we opened a facility probably a couple of years ago now, where we identified a gap for our adults who live with mental health challenges. They didn't need 24/7 residential care. Their needs were such that they couldn't go immediately into independent living. They needed something in between, and we identified that as a gap in support, and opened a unit that was a reablement unit that would support them to progress toward independent living, but in their own time and taking account their needs for that. So that's the sort of ideal, but it does tend to be a longer journey for people, I think.
Thank you. Lewis, any comments, questions? Graham?
Yes, I wanted to ask some questions about the funding on Appendix 2. More to sort of learn a bit more about how this works, actually, because I wasn't quite sure I understood it. What defines whether you get a Band 1 or a Band 2 financial contribution as a carer? That's the first one.
It's need. So the needs of the individual will be higher or lower. The need for care, the need for support, and that will therefore dictate as to whether it's Band 1 or Band 2.
And it also says that if there are exceptional needs, high-level physical needs, then there's another band above that which isn't actually shown, which is the extra one you get on that, right? Okay. Sorry, it also says that the person who's caring gets a payment, which presumably is based on the minimum maximum there. Then the resident themselves, who is there, gets potentially payments, including that would be what, social security benefits, or, as you say, their housing benefit. Does that matter whether the person is living in rented accommodation, i.e. the carer is living in rented, or whether they're living in a owned property?
I think the only impediment would be if there was some kind of subletting clause on the rented accommodation. I mean, generally these are households. Generally they are owned households, but we wouldn't exclude people that rent. So I think there would be, we need to understand there was no subletting kind of clause, but that shouldn't impact really. It should be based on the circumstances of the carer as well as the individual.
And somebody who takes someone in as a carer, they might be living on their own, they then have someone to care for, they would lose their single person discount on the council tax. Is that compensated for within the charges that they get paid? Is that the assumption how that works?
I don't think, I would hesitate to say it's calculated that in such detail as to compensate for that. I think it's calculated to understand and to accept that there's a job of care being provided, if you like, for the individual, that it's, whilst it may be their own home, they need to satisfy certain standards. They are, the service is regulated. We have regular touch bases with our carers, with our shared lives officers. So the payment is compensation for that, or payment for that, if you like. I don't think we calculate precisely around things such as if the person is in if the person is a single occupant, how that then impacts on any benefits they might get.
So the next question would be, would that also be true for someone who may be a property owner, who maybe pays council tax but is getting income as a result of being a carer, which then means that they're not able to claim council tax benefit?
Yes, theoretically that could be true.
Right.
Richard, did you have anything else to add from a finance point of view on that?
Nothing to add, thank you.
Excellent. See, Andy's doing you out of the job. See the horror on Andy's face there for people who can't see at home. Yeah, I mean, thanks so much for the report, Andy, and from Marie, obviously, as Head of Provider Services. Shared Lives is a fabulous service and really does make a difference, not just because it's for what people have the kind of care and support they want, but also it is, as Andy's pointed out, incredibly cost effective. So again, just picking out the bit of the reports in terms of that, which it can be a savings delivered of between £8,500 and £60,000 per annum, which is quite substantial, and therefore it makes absolute sense for us to be looking at expanding the service with the support of Shared Lives Plus, the national organisation that brings together the shared life services around the country. So I'm really looking forward to the work that's going on and getting reporting back on that. And again, just picking out that we'll get a report and presentation in January, and then a phase 2 of this work will be to map service users who could benefit from the service in the next 3 years. And obviously, I would encourage anyone watching or knows anyone that might, and obviously colleagues as well, who might be interested in shared lives caring, to approach the council, let them know. We are always keen to have anyone else volunteer their services and give the kind of care and support that people who are wanting to have that service and that kind of living environment can have. So thanks so much for the report, Andy, and say to Marie as well, and all our shared lives carers, a massive thanks to them for the work they do. They are, as with the carers we were talking about, the unpaid carers we talked about earlier, we could not do what we do in this city without them, so we are extremely grateful. So happy to note that report, and that concludes the meeting, everyone. Thank you very much.